Hello everyone, my name is Janice Baker. I want to introduce myself and I'd love to hear a little bit about what you do when we're on our break, but we have a small amount of time at the beginning and then we'll continue after our break as well. Just to introduce myself so you know who I am and what I do, I'm a registered dietitian, certified diabetes educator, certified nutrition support clinician, and board certified in advanced diabetes management. And I've been in practice since 1983. I worked for 12 years in acute care in the med-surg critical care area of the hospital, cardiac rehab. And for the past 25 years, I've worked in outpatient services, seeing patients individually, but I teach a lot of classes in the community. And I work with Palomar Health in the Poway area, Escondido, Ramona, as well as Arch Medical Group. So being that I've been in practice for a long time, I've seen a lot of things, and a lot of things change. And interestingly enough, we know now that so many things are being done and taken care of in the outpatient setting. And what I'm noticing in my outpatient work, I'm doing a lot of what I used to as an inpatient dietitian. And what we're recognizing more and more is nutritional concerns on the outpatient side, including malnutrition, chronic disease management, a lot of things that are all mixed together. And my real passion is to be a resource for you as providers of such important healthcare and to help you recognize when nutrition issues come up and what some disease states sometimes need to be considered with dietary changes. And I'm really happy also to hear your questions. I'm thrilled to be a resource because you are out there seeing patients and taking care of so many issues. So the first handout I have today is what I actually use quite a bit of in my clinics. And this is called Ask About Your Nutrition. And I give this to both our healthcare providers as well as our patients and their families alike. Malnutrition is very under-recognized. It's very under the radar. And so what we try to ask our patients about is, have you had any unintentional weight loss? Even in a larger size body, unintentional weight loss is a very big marker for something that's wrong metabolically, gastroenterology-wise, taste changes, dental changes. But no matter what, that's not a good marker of anything. Second is loss of appetite. Has their appetite changed at all recently? Because that's also a marker of some possible chronic disease state, mental health as well as oral health problems. Only able to eat only small amounts, they fill up easily. Do they eat like half of what they used to at a mealtime? That could be a GI issue, depression, other things that can lead to malnutrition. Feeling weak or tired, people are weak and tired for many, many reasons, but malnutrition certainly causes that. And swelling or fluid accumulation. Now that happens in many disease states like kidney disease and heart disease, but we do notice that because it can be also a marker of poor nutrition and other metabolic issues, cardiometabolic issues that can point to issues that have a lot to do with nutrition. So this is a nice infographic, and on the back, even more pictures that more illustrate those things. Weight loss, low body mass index. I want to remind you, though, that malnutrition can happen at any size body. So we see people with larger bodies with malnutrition. I actually see that all the time. Muscle tissue loss. People can maintain their weight, but they can have more weight around their stomach area and really depleted muscle loss. And loss of muscle is really related to wound healing and functional status, like being able to open up a jar or pushing themselves out of a chair. So I look all the time at muscle tissue loss. Assimilation loss, that basically means malabsorption, maldigestion. That can happen with medications or a GI issue. Some people, I'm working with a lot of people who have chronic diarrhea, or they're taking medicines that cause GI issues, so that can be a part of the problem. Lower intake, as we talked about, and an inflammatory process. That could be cancer, diabetes, even excess fat around the stomach can cause an inflammation process, some infection, wounds that are trying to heal, UTIs, in any kind of infection or inflammatory state can really increase nutritional needs and accelerate muscle loss. So these are a lot of things that can lead to bottom line malnutrition. And it's a slippery slope. It accelerates as time goes on in many cases.
So you were saying that that was interesting, that muscle loss itself can cause malnutrition?
Well, it's a sign of malnutrition, but it's a bidirectional effect because muscle loss is all over the whole body, and as we'll talk about a little later, that muscle loss can include the muscles that help us swallow and push food through our GI tract. So when you have weakened muscles all through the GI tract, then you fill up, you can't swallow. It's a vicious cycle. So it's both ways. And then when you don't have energy, because you're weak, you don't want to cook so much. So there's both relationships. So that's
medication can cause
a lot of medication, constipation. That causes you to not want to eat too. Yeah. So there's a lot of what we call drug nutrient interactions, and again, people lose weight, then their medications aren't always changed appropriately, or as time goes on, we know polypharmacy, especially in our seniors, so many medications get in the way of proper nutrition too. So you've probably seen that quite a bit. The next handout I have is one I use. I actually teach a lot of nutrition classes for seniors, which are very popular because they're interested in it and they're living this issue. So this goes through some of the nutrition-related concerns. And actually, again, we know that issues like diabetes and heart disease do indicate sometimes we need to be careful with diet, certain dietary components that I'll be talking about. But at the same time, when their food intake is so limited, their fear of eating can cause malnutrition in itself. So we have to really look at each person's individual status to see do they really need to be so careful about their sodium intake or carbohydrate intake, because all those restrictions can cause loss of body weight and malnutrition. So we have to be very careful about the recommendations. Of course, things like osteoarthritis, osteoporosis, some cancers, of course, affect nutritional status. I'm working with a lot of people with gastroesophageal cancers, colon cancers, and cancer itself, because of the change in metabolism, can cause acceleration of muscle wasting. And of course, the treatments can cause poor appetite, which is very hard to reverse as time goes on. So we're trying to emphasize really good nutrition right at diagnosis, especially before treatments start, because of the loss of weight and sometimes break in treatments that need to happen if they get way too weak. Of course, high blood pressure as time goes on, that's a common thing. We need to look at sodium intake, but again, we need to look at the overall picture. Many people are treated with multiple medications for high blood pressure, and then that is often also related to kidney function, which can affect other things like other nutrients, like not only sodium, but potassium, phosphorus, fluid, if their kidneys are making enough urine, fluid balance. If they're on dialysis, that's another issue that we have to talk about. Again, swallowing and chewing, we're going to go over that a little bit later. I have some good handouts on oral health. And a lot of people have heartburn and reflux, and they're on medications for that to control that. Well, the medications may be important because it protects the esophagus from damage. But at the same time, some of those medications can interfere with nutrient absorption. The biggest one is vitamin B12. That's also interfered with use of metformin for diabetes. So B12 deficiency is something we're needing to check for a lot more because that affects the nervous system function. So with heartburn medications and diabetes medicines, we're paying attention to that. So again, this is something that's great for all of us, no matter what, but we want to encourage activity. Again, plenty of fruits and vegetables in the proper way that people can eat them. Fresh, frozen, or canned are all fine, depending on what their abilities to cook and what their needs are. Plenty of protein, because relatively speaking to their body weight, seniors need more protein to maintain muscle tissue and immunity. And we recommend getting the protein in divided doses, some protein in the morning, in the midday, and the evening, because their bodies can only take up so much at once. And also, again, people are not typically eating a whole lot at once as well. So in between meals, some protein-rich snacks like yogurt, string cheese, cottage cheese are easy to eat, don't need much cooking or preparation, and again, help support lean body mass. So we talked a little bit about sodium control. In some cases, we need to look at that when there's fluid retention, heart failure, kidney issues that needs to be looked at, but in the context of making sure they're eating enough. So a lot of our patients who may have heart failure, which is common after years of diabetes and high blood pressure, they get what we call cardiac cachexia. They just fill up easy because of all the other inflammatory issues that come from cardiac cachexia, and you'll notice they're losing a lot of muscle tissue. They fall asleep easy, they're short of breath, they just don't have a lot of appetite.
The heart itself is
it's the heart failure, yeah.
Could you spell the cachexia?
Cachexia.
Thank you.
And it's sort of very similar to cancer cachexia. Because again, it's an inflammatory process. There's a lot of physiological biochemical changes, and they just fill up very, very easy. This is what my father passed away of heart failure, related to diabetes. And so he was always a great eater. He lost his appetite. He lost a lot of muscle tissue. He was always falling asleep in his chair because when your heart's not pumping, you didn't get blood perfused to your brain, to your kidneys. It really weakens people quite a bit. So I wasn't holding back on any food for him. I just wanted him to have food he enjoyed and was easy to eat because he filled up so quickly. That's sort of the nature of the progression there as well. So dental care, we'll be talking about that because I have a great, great handout on oral care. Good shoes are very important because especially for our people who have diabetes, they lose protective sensation in their feet, and fall risk is very high. So very good shoes is something I talk about all the time because it's related to mobility. And again, you know, decreasing the risk of falls is everything. That's the biggest deal. And vitamin and mineral supplementation is needed. I'm seeing a lot of seniors pounding down supplements because they're very profitable. There's a lot of marketing and a lot of emphasis on, oh, the supplement is anti-aging and all the other things that go along with it, but they can be actually quite dangerous in many cases. There can be toxicities. And I work with gastroenterologists, and they see a lot of liver damage from a lot of over-the-counter things that are not regulated. So we have to be careful about what supplements our seniors are taking. They can be taking even a multivitamin with extra iron and get iron overload disease because they don't need all that iron. So that's another issue. They could be taking weight loss supplements that can cause heart issues as well as liver damage. So that's something I have a lot of seniors come into my office with bags this big of supplements filled. And they're spending hundreds of dollars on these. I can't tell you how many times I'm seeing that. They could be spending that money on other things. So again, hydration is a very big issue. As we know, as time goes on, their sense of thirst diminishes. And one of the biggest reasons for a hospital admission, anyway in my experience, is dehydration. Because they lose that sense, and then it causes them to be confused, and then even more so, they don't drink water. So this is especially something we have to pay attention to if our seniors have diabetes, type 1, type 2, it doesn't matter, because very slowly they can develop what we call hyperosmolar hyperglycemia. Hyperosmolar hypoglycemia, they're, slowly over time, their blood sugars are going up, they're dehydrated, and they can get to a real difficult state where we find their blood sugars in the 600s, 700s and above, and they're dehydrated, and they need to be in the hospital with IV fluids, and it often doesn't end well. Okay, it affects vision, all parts of their body, and it's often triggered by something like a UTI. Okay, you see that, right?
My mother.
Yeah, it's classic. So that is why hydration is such a big deal. And then medication management, reviewing what meds they really need. I'm seeing also a lot of attention needing to be looked at diabetes-related medicines, because the cheaper ones, like the sulfonylureas, which is like glipizide, glyburide, glimepiride, do cause hypoglycemia, do cause falls as a result of that. So we're really focusing, especially on diabetes management, to minimize the use of those particular medications. They're inexpensive, so they're used more for that reason, but they're dangerous for seniors because of their higher risk of hypoglycemia, which seniors often are not aware that are happening. And that even overnight. They get up, oh, I'm just a little shaky and sweaty. I'll go downstairs to get a glass of juice. Well, I've seen fractures happen due to that. So looking at their medications and whether we need to adjust for that. And, coincidentally, I'm also seeing seniors needing to use the older classes of insulins because of cost. The old NPH and regular, if you're old enough like me to remember those old insulins, you never know when they're going to kick in. Yeah, so because of the pricing of insulin and limited budgets, we're going back to the 80s in some cases, which is a dangerous thing medication-wise for many seniors. So alcohol, I have to mention too, alcohol is a drug and it interacts with other medications. And as time goes on, that can cause not only low blood sugar, but malnutrition, as well as falls and fractures. So people are going to do what they're going to do, but I bring this up all the time. Okay? So on the back of this paper, again, we talked about this before, common reasons for weight changes, up or down, medications, activity changes, other health issues, and special diets for health concerns. If necessary, we have to be very careful about restricting, but sometimes with high blood pressure and fluid retention, the sodium needs to be looked at. We want to emphasize fruits and vegetables. Diabetes, we don't restrict carbohydrates, but we want to keep it consistent throughout the day. And if they're taking basal bolus insulin, both fast-acting and basal insulin, matching up the fast-acting or nutritional insulin with their with their food, with their carbohydrate. And blood sugar monitoring is important in that case. But we try our best as time goes on to help to relax how much medications they're taking. So sometimes as time goes on and the kidneys are not as functional, the kidneys will be not as good as clearing insulin from the body, so we need to reduce insulin dosages because it can build up easier in the setting of chronic kidney disease. Okay, so high cholesterol, we're finding out more and more that we don't need to be so stringent with dietary changes with high cholesterol. We know that a lot of times it's genetic and it's more medically tailored in terms of controlling cholesterol levels. It really depends on the person. We're not saying anymore don't eat egg yolks or things like that. Of course, it really depends on the person's situation as well. And again, we talked about heart failure, sodium control, fluid restriction. With cancer, which I work a lot in oncology, we have to understand, first of all, where the cancer is, what the treatment is, but knowing that there is such a malnutrition risk in the setting of cancer because of treatment and the stress on the body, really building up the person's nutritional status as much as possible and reducing the risk of malnutrition is a very big part of the care. Unfortunately, sometimes by the time I see patients in the setting I'm in now, they've lost a lot of weight and it's very, very hard to restore that. So again, chewing and swallowing problems with dental issues, weakening of the muscles of the throat, the esophagus, can get in the way of proper swallowing. And then the issue with silent aspiration. People getting fluid or food even into their lungs without knowing that. And that's a big reason for pneumonia.
Dementia.
Dementia, that sort of thing too. So we have to look at the The texture modifications, we'll be going through some of that. We have to go through, looking at referral to a speech pathologist and evaluating for safety of foods and textures. And in some cases, looking at the possibility of needing a tube feeding, G-tube and G-tube, which we try to avoid as much as we can because there's risks and benefits to that. But sometimes it's needed even just for a while. But it really depends on what the intended outcome is and what the safety issues are. And then also food and drug interactions. This is where I tell my patients, and we talk about a lot, asking your pharmacist how to take medication properly, how does this medicine work, what to look out in terms of side effects. Okay? So a lot of different angles to this. We got to also look at enjoyment of food. Food is a quality of life issue. And we must, again, allow for the fact that taste changes, sentimental issues around food are a real thing, and it should be a joy in life. So shaming someone for eating a cupcake on their birthday or, getting in the way of special celebrations because you're afraid to have sugar, I see this a lot. I see a lot of food anxiety, even in people in their senior years, which really doesn't help anything. So, that's something that's happening, of course, across all age ranges, but especially seniors. We need to really make sure that we're understanding food and eating should be fun, a quality of life, and something they look forward to. Any questions? Comments?
I have a question about the heartburn reflux
Yeah.
related to vitamin B12 deficiency.
Yeah.
What were those? You listed the class. Which one?
Yeah, it's the H2 receptor, and the PPIs, both of them. And again, talking to a lot of GI doctors, they admit being very careful about them because it's weighing out the risk benefits. So we see when there's a lot of acid reflux, you can do damage, and we have a higher risk of esophageal cancer. The precancerous cellular changes, it's called Barrett's esophagus. And we're seeing more of that happening because of the reflux. It sometimes can be due to excess weight in the abdominal area that pushes up and puts additional pressure on the GE junction here. So sometimes when appropriate and safe, weight loss will help, as well as mobility, eating smaller meals throughout the day, elevating the head of the bed, not eating and then just laying down. Alcohol is a very big reason for cancer of the gastrointestinal system, so looking at that as well. But sometimes these medications are needed, or pro-motility medications as well. So it needs to be individualized.
So the vitamin B12, that would, if getting rid of the meds or lowering the meds, it's not an option.
Yeah.
The vitamin B12 injections.
It's actually, you could do it a couple ways. I often recommend to all my patients with diabetes, for example, who are using metformin, a sublingual B12. It's a little tiny tablet that melts under the tongue, and that can often be adequate, so you don't need injections necessarily.
Like a daily supplement.
Yeah, daily, and you can get this anywhere. It's very inexpensive, but it's sublingual B12.
Not the oral. Just
yeah,
lost in the
yeah,
GI.
you want it under the tongue. In fact, this is routinely advised to patients, which you will see more of, who've had the weight loss surgery. I work a lot in bariatric surgery, and anyone with weight loss surgery, it's gastric sleeve, where you take out 80% of your stomach, or Roux-en-Y bypass surgery, which is not done as much today, but it's been done a lot, maybe more 5-10 years ago, plus some. You're going to see a lot of patients who've had those surgeries because they're much more common in seniors. Medicare is covering it. So you're going to have malabsorption and malnutrition if they are not taking the supplements that they should be. I'm very, very direct about how important that is. But a lot of people stop, and they're going to get malnutrition related to the weight loss surgeries that are becoming more and more common. But all of them need to take, excuse me, a sublingual B12 because they're not absorbing it in their stomach because their stomach is 80% gone. So they must take those bariatric specific supplements.
Thank you very much.
Yeah, very good question. Any other questions on this? Okay, so in the last picture I have, I love this, I use this a lot, and this I think is very telling. This is a cross-section of the quadriceps muscle, and it really illustrates how it's hard to see things from the outside when it comes to muscle wasting, but this shows the difference. Again, cross-section of the upper thigh, active, healthy, both a 40 and 74-year-old, very functional, strong muscle, very metabolically active. Even the bone is well supported. You see, even the bone looks better. And this is somebody in the middle who actually has a lot of not just muscle wasting, but the muscle is not very functional. It's very infiltrated with fat. And this is a person, when I took this picture around to the doctors I work with, I asked them, how many medicines do you think this person in the middle is on? Most of them said between 15 and 20 because of probably diabetes, high blood pressure, high cholesterol, probably some pain medicines. Along with that, this person is not getting up from their chair or walking very quickly. And this is, an indicator of the whole body. This is not just in the legs.
Yes.
So not just how much muscle mass we have, but how functional it is. Those are the two things we are really looking at. And in fact, now in our critical care nutrition support, we are really even in the ICU implementing physical therapy, good quality nutrition support, because the more people are immobilized on top of the stressors that happen if you're in the hospital for any length of time, especially in ICU, you rapidly lose muscle tissue. And then there's something now that we're calling post-ICU syndrome, where when you're in that intensive care unit and so immobilized and so critically ill for, even a short period of time, it can take up to 2 years to recover from all the weakness that happens when you're intubated and you're immobilized, or you have trauma or infection, sepsis. It just pulls the muscle like no tomorrow, and then to restore that takes a lot of work. So we're looking at, whether are we creating victims or survivors?
You call that post-ICU?
Post-ICU syndrome. Yeah. So this is really being looked at very closely in nutrition support and critical care. And if you have patients that have been hospitalized in the ICU, in the hospital for any length of time, their muscle tissue is quickly mobilized because of the inflammatory state for healing purposes, and just because they're not moving, it rapidly wastes away. So to rebuild that, we're really looking at PT, rehabilitation, as well as nutrition. In fact, now there's a big movement called ERAS, Enhanced Recovery After Surgery, where if we know people are going to have an elective surgery, we're likening that to getting ready for the Olympics. You don't just run a marathon just because you decide to. You train, you eat right, you train, you do what you need to get your body in the best shape possible. Now we're starting to emphasize, if you know you're going to have an elective surgery, this is like an athletic event. Build your body up to the best place possible so you can restore and recover and heal as best as possible. So enhanced recovery after surgery, or we sometimes call it prehabilitation, very big deal. Okay? So we've talked about a lot in a little bit of time. And at this point, I think we're ready for a little bit of a break. And then after the break, we're going to continue on with some other handouts and topics.